Welcome to the Speaking of Women's Health podcast. I'm your host and author, Dr. Holly Thacker. Thanks for joining me back in the Sunflower House for Chapter 13, Abnormal Bleeding and What to Do About It. Here's an interesting question. What constitutes abnormal bleeding when you're entering into menopause and you're expecting changes in your normal menstrual pattern anyway? Well, it's hard to say. Changes in menstrual bleeding are natural because they're so common during perimenopause because your eggs are aging. Your flow may be heavier, you might get spotting, and the time between your periods may be longer or paradoxically shorter. Linda. It's been years since Linda has worn white pants or a white skirt. As she moved through her 40s, her menstrual periods got heavier and heavier, to the point where 2 supersized tampons and a thick pad were barely enough. She visited her local gynecologist, who was rushing to sign her up for a hysterectomy. Both her mom and sister had had hysterectomies, so Linda figured she'd probably need one too. But she was concerned that she wasn't offered any other options, so she decided to seek another opinion. When I saw Linda, I ordered a complete blood count and thyroid functions and a ferritin level because low thyroid can cause heavy periods. And despite taking an iron tablet with vitamin C every day, she was anemic with a hemoglobin of 9. The normal is 12. When I asked her if she was craving things that weren't food, she sheepishly admitted that she would chew on aluminum can tops. The medical term for this is pica, and it's a sign of very low iron. Her general practitioner had already ordered a complete GI workup, and she had undergone an upper endoscopy and colonoscopy in order to check her intestinal tract and make sure there was no other signs of occult blood loss. Her GI workup was normal. However, I discovered that she had not been tested for von Willebrand's disease, which is an inherited bleeding disorder often overlooked as a medical cause of heavy bleeding, or platelet defects. I was suspicious about this because she had bled very heavily with a routine dental extraction as well, and also during her one vaginal delivery. She had almost required a blood transfusion after she gave birth, but she noticed that her periods were much better controlled when she took the hormonal contraceptive agent. Well, the von Willebrand's panel came back, and indeed she had a mild form of von Willebrand's disease syndrome. So she was treated with DDAVP nasal spray for her bleeding disorder. I still recommended that Linda get scheduled for an office hysteroscopy to make sure we weren't missing any structural problems, even though her prior endometrial biopsies and pelvic ultrasounds by her local gynecologist were normal. As it turned out, she did have a very small polyp that was easily removed through the hysteroscope with an in and out DNC procedure, which is dilation and curettage. With the treatment of her mild von Willebrand's and the removal of this polyp, her blood count returned to normal, and she did not require hysterectomy. This chapter is about abnormal bleeding and its treatments, including but not limited to hysterectomy. Once again, it's mostly about choice. I want to be sure if a hysterectomy is recommended to you that you understand your diagnosis and you've investigated all of your options. Too many times, women are not informed of their therapeutic choices. And certainly in the past, hysterectomies, I think, were done a little bit too frequently and gratuitously. On the other hand, sometimes I think that people wait too long to finally offer a hysterectomy, and that women who are post-childbearing don't necessarily need to do backflips to save the uterus. Now, like I tell all my patients, my bias, being a menopause specialist and anti-aging specialist, is that it's a lot easier if a woman doesn't have a uterus come time for menopause because estrogen is cheaper, safer, and there's no bleeding. And unfortunately, the uterus is made to bleed, and it is kind of a bugaboo. That being said, I do have women in my practice in their 80s and even a few in their 90s who still have their uterus, and have been maintained on hormone therapy. So we never want to jump into a surgery with anesthesia, possible risk for injury, infection. We certainly don't want to just think it's so minor, even though we do it every day and it's such a common procedure. So how do I know what's abnormal? Well, remember that earlier we defined menopause as not having a period for a good 12 months? We also said that if you have any bleeding after 6 months without a period, it should be checked out, even if it seems like a regular menstrual period to you, even if you feel like you've ovulated. Variations in bleeding can range from light spotting to a discharge comparable to a menstrual disorder. In severe cases, women can actually flood, leaking blood through tampons and sanitary napkins. Women who've had this experience many times are naturally afraid to leave the house to run errands, and they worry about whether they'll have an accident at work. And it certainly takes a toll on their intimate life. Abnormal bleeding can be an isolated incident for some women, but for others it's a recurring situation. And sometimes abnormal bleeding is accompanied by abdominal pain or lower back pain or pelvic cramping or bowel or bladder disorder. And bleeding can sometimes signify a serious health concern, which we will identify below. Should I be worried about bleeding after the onset of menopause? Well, abnormal bleeding from the uterus, vagina, or cervix can be very, very scary. The first concerns that come to mind, of course, are cancer, such as uterine cancer or cervical cancer. Panic may strike in women. In most cases, however, women who have abnormal bleeding, it's usually for benign or easily treated hormonal reasons. And actually, some uterine and ovarian cancers can present with no bleeding at all. And all women who have a cervix, who are between the ages of 24 and 65, should have regular cervical cancer periodic screenings, and sometimes longer than that if they've been abnormal. So please don't panic if you've had abnormal bleeding, and try not to jump to the conclusions that this is cancer or a life-threatening illness. However, you do need to see a women's health physician to get checked out. Fast fact: sometimes a uterine infection will cause spotting or abnormal bleeding. This is one reason I tell women not to do any douching. It can shoot bacteria up into the uterus and cause a low-grade infection that can result in abnormal bleeding. If you feel the need to douche, don't do it. Just wash with plain soap and water, and you can use over-the-counter Refresh vaginal gel instead. It's simply a lactic acid that helps lower the pH of the vagina to a more healthy pH that inhibits bacteria and inhibits.
We'll be back after a quick break.
Hey, quick question for you. Are you someone who wants to be fit, healthy, and happy? And what if I told you could get your dream body by simply just listening to a podcast? I'm Josh.
And I'm KG, and we are the hosts of the Fit, Healthy, and Happy podcast.
Listen, we get it. Fitness isn't easy. Carbs, no carbs.
Just stop, okay? It doesn't have to be that complicated. And that's why we made this podcast. We get straight to the facts so you can become your best you.
So the way to check us out is click the link in the show notes or search Fit, Healthy, and Happy podcast on any of the major podcast platforms. We'll see you soon.
Yeast. Is hysterectomy the only treatment for abnormal bleeding? Well, prior to contemplating hysterectomy, a woman with unexplained heavy bleeding should be evaluated for a mild bleeding disorder or a subclinical thyroid condition, or perhaps for a submucosal fibroid or a polyp. Or you may have both. I had both. Many women in my practice who suffer from severe menopausal symptoms have had hysterectomies as their first-line option. And I asked them how they're feeling, and some who did not want to have a hysterectomy are angry and feel violated, and no one told them that there was another option. And sometimes these side effects of hysterectomy can be psychological as well as physical. They may feel cheated. Of course, many women are so thrilled to not deal with a monthly period or worry about a surprise pregnancy. And after hysterectomy, many women make a very smooth transition into menopause. If you're ever going to have pelvic surgery for a tubal ligation, certainly remove the entire both tubes because that reduces ovarian cancer. And if you're going to have your uterus removed, certainly the decision about keeping your ovaries is a very important decision. And usually we recommend keeping healthy ovaries at least till age 65 unless there's a genetic condition that increases the risk, or diseased ovaries, or a family history of ovarian cancer. But by all means, please also take out those tubes because that's where most ovarian cancer begins. So my goal is to help you understand surgical solutions to the various types of abnormal bleeding and make sure you know how to get the information from a knowledgeable physician who can steer you towards the option that may be right for you. So there are non-hysterectomy alternatives. For example, if your heavy uterine bleeding evaluation is negative, you might be a candidate for the insertion of an intrauterine system called the Mirena intrauterine system. It is a contraceptive, but it is also FDA approved to treat abnormal bleeding because the constant application of a progestin will slow down the menstrual flow or even stop the flow. And this was originally approved for 5 years for contraception and is now up to 7 years. And certainly to protect the endometrium is good. Most people agree at least 6 years. However, in cases where the uterus is very large, like up to your belly button, which is a 20-week size pregnancy or a 4-month pregnancy, because of uterine fibroids, particularly if the uterus is pressing on other organs like your kidneys, then you will need a hysterectomy. But this decision has to be made after careful considerations. Here are some important questions to ask. Do you need the hysterectomy? Did your physician explain non-invasive procedures for treating uterine fibroids, pelvic prolapse, endometriosis, endometrial polyps? Are you aware there are options other than removing your uterus and ovaries, which sends the body immediately into abrupt surgical menopause? Investigating the cause. Abnormal vaginal bleeding after menopause can have various causes, from hormonal imbalance, inflammation, infection, injury, atrophy, or abnormal growth, whether benign or malignant. And these can cause bleeding that's erratic. Specifically, hormonal imbalance, too much estrogen or not enough progesterone, which is very frequent in perimenopausal women, can cause abnormal bleeding. And so can the absence of regular ovulation. Vaginal atrophy, a very common cause of bleeding, which is due to excessive thinness of the lining of the uterus because of not enough estrogen. And it can lead to the lining being thin as well as the vagina being thin, which can contribute to bleeding. Uterine fibroids. These are non-cancerous growths, especially in the submucosal type that press on the lining of the uterus. And this can cause abnormal bleeding. Now, I used to tell women that 1 in 2 women had fibroids after the age of 30 or 40. Now we know it's over 80% now that we have such good ultrasound. Endometriosis. The endometrium is the lining of the uterus. And whenever the endometrial tissue is somewhere else besides the lining of the uterus, that's endometriosis. And adenomyosis is a common cause of pain and bleeding. And that's when the lining of the uterus grows into the muscle. It's a little more frequently in women who've had children, especially C-sections. Anovulatory bleeding is when you don't make an egg every month. And it's responsible for up to 70% of abnormal uterine bleeding. A uterine infection. This can occur spontaneously or specifically as the result of a sexually transmitted infection. Endometrial hyperplasia. This can occur spontaneously because the lining thickens and doesn't shed. And it's a breeding ground for abnormal cells and possibly a precursor to uterine cancer. If you have atypia on your endometrial hyperplasia, this is a concern and a precursor to endometrial cancer, meaning there's at least a 30% chance. And most of the time, unless you're very unstable and not suitable for hysterectomy, most of the time a hysterectomy will be recommended. Now, in women who want to preserve their fertility or are a bad operative risk, sometimes a Mirena intrauterine system will be inserted with periodic biopsies. Cystic glandular hyperplasia. There's too much uterine lining, but generally the endometrial cells are normal. And we usually give cycled progestogen and then rebiopsy. Adenomatous hyperplasia is a more advanced type of hyperplasia. These cells are larger but still not cancerous. But atypical adenomatous hyperplasia is severe hyperplasia, and the endometrium is consumed by abnormal cells that are not necessarily benign. And we usually treat this like an early cancer with curative hysterectomy. What about uterine cancer, endometrial carcinoma? Well, this does require a hysterectomy, and it's usually curable if diagnosed early. Please don't delay in seeing your gynecologist or a women's health specialist if you're having abnormal bleeding. So which test should I have? If you're having abnormal bleeding, a medical evaluation is the first order of business, including a pelvic exam, a thin pap smear, and an HPV DNA test. Next, your physician will investigate the bladder and colon. You may need a colonoscopy to rule out bowel problems. Sometimes women aren't sure if blood comes from the rectum or the vagina or the urethra. Assuming your evaluation is clear so far, there are other tests a knowledgeable physician can make to determine the cause of bleeding and whether a hysterectomy or other treatments is necessary. The dilation and curettage, so-called D&C. Until relatively recently, gynecologists have depended on D&Cs to clean out the uterus. But a big drawback to many D&Cs is they're done, quote, blind, meaning a tool is inserted into the uterus through the cervix and the area is scraped. And the doctor can miss fibroids or abnormal cell growths or very small polyps. So the D&C procedure 1 or 2 might not necessarily control the bleeding if the actual problem's not removed. Fortunately, we have more modern options that many gynecologists employ. Operative hysteroscopy. Most gynecologists are able to put a lighted scope in to look around through the cervix, into the uterus, and up at the tubes. Some gynecologists are able to do this in the office. I have had an office hysteroscopy done and hopped off the table and went back to seeing patients. And this instrument can be used to examine the endometrium as well as collect a biopsy sample and help guide minimally invasive surgery to remove any abnormal growths without having to do a hysterectomy. It usually takes 20 to 30 minutes and can be performed during an office visit if the gynecologist is skilled. But usually if there's polyps, and certainly if there's submucosal fibroids, that needs to be done in a surgical suite with anesthesia. If you need a hysteroscopy or saline infusion sonography, you might want to ask your physician or nurse practitioner if you should take 200 milligrams of Cytotec, generic name, misoprostol, orally to dilate the cervix, because especially if you've not had a vaginal delivery, this could make the procedure easier on you. Transvaginal pelvic ultrasound. A small ultrasound device is inserted into the vagina to produce a picture of the uterus and pelvic structures. This test can help determine whether uterine fibroids are present and whether the uterine lining is too thick. Generally, we want it to be under 5 millimeters, and 4 millimeters or less is usually reassuring. An ultrasound also may allow visualization of one or both ovaries. Saline infusion sonography is done by a gynecologist as opposed to a radiologist, and that's when sterile saline or salt water is passed into the uterus through a very tiny, soft plastic catheter. And the infusion of saline separates the uterine walls so that from a 3D version, the sonogram can identify any irregularities of the inner uterine wall. Whereas a regular 2D ultrasound often cannot capture these specific images. And many times polyps in the uterus or localized thickening can be identified. Uterine fibroids. They are muscle overgrowth, nodules, small collections of muscle tissue made up of smooth muscle cells and fibrous connective tissue that can develop within the wall of the uterus. Medically, they are called uterine leiomyomata. The singular is a leiomyoma. Fibroids may grow as a single nodule or in clusters and can range in size as small as 1 millimeter to more than 20 centimeters, which is 8 inches. They may grow within the wall of the uterus, or they may project into the interior cavity towards the endometrium, or towards the outer surface of the uterus. When they grow on stems that project from the surface of the uterus, they're called pedunculated. Most women with uterine fibroids will never know they have them since symptoms are not always present. But some women will have symptoms which can include abnormal bleeding that mimics a heavy period, longer periods, bleeding between periods, a sudden heavy flow after not having a period for several months, pelvic pain, pain during sexual activity, lower back pain that doesn't go away, abdominal pain, urinary or bowel problems. Are fibroids painful? Fibroids of small to moderate size that do not cause symptoms and are confirmed as benign by a knowledgeable physician generally do not need to be surgically removed. And they may never cause symptoms or be painful. And after menopause, many times fibroids shrink and go away. However, when fibroids grow large, they can push on organs like the kidneys, cause pressure in the back or abdomen. And in severe cases, clusters of fibroids can grow so large that they outstrip their blood supply. And when this happens, the uterus and fibroid both shrink, causing like a muscle attack, like a heart attack of the uterus, so to speak. And this can cause severe pain. And this can sometimes be so acute that it does lead to an emergency hysterectomy. This is pretty rare. Fibroids can cause pressure in the back and abdomen when they grow and press on surrounding organs. So, how are fibroids treated? Well, once your physician confirms the reason for your abnormal bleeding, pelvic discomfort, or chronic pain, if it's a fibroid or several of them, he or she will discuss a few treatment options with you. In addition to diagnostic office hysteroscopy, followed by potentially operative hysteroscopic resection of the fibroid, options include open surgical myomectomy to remove the fibroid if it isn't accessible by the hysteroscope, or simply a hysterectomy to remove the fibroid and the uterus. On rare occasions during a complete hysterectomy, the ovaries are removed. And we'll talk about that a little bit later.
We'll be back after a quick break.
Have you ever experienced fitness failure? You know, you set a goal to exercise, you're all excited, and then you're not. Hi, I'm Dave. I host the daily 10-minute podcast, Walking is Fitness. Instead of an exercise goal, I talk about making a fitness promise. And every day you keep that promise, you add another link to a growing fitness chain. This is a podcast of action. You'll create a fitness habit, which eventually becomes fitness momentum, and then on to all kinds of good stuff. Check it out. Walking is Fitness, and let's take a daily 10-minute walk together.
More and more physicians are beginning to realize that uterine fibroids may not require any intervention or limited treatment. For a woman with uterine fibroids that aren't causing symptoms, the best option may be watchful waiting. Myomectomy options. Depending on the size, location, and number of fibroids, your physician may recommend one of these surgeries to remove the fibroids, falling under the umbrella of so-called myomectomy, meaning excision of a myoma, a tumor consisting of muscle tissue. These options usually are favored over hysterectomy because a hysterectomy eliminates completely the woman's ability to give birth. You might not ever be interested in childbearing, or you might have been completed childbearing, but if you develop fibroids while you're still planning a family, or you simply want to avoid major gynecologic surgery, again, you need to know all your options. Before myomectomy, Lupron injections can be used to shrink the size of the fibroid. Lupron is a gonadotropin-releasing hormone analog, so-called GnRH analog, and this decreases the body's production of estrogen to a menopausal level. It's not long-term treatment because this puts a woman into temporary menopause, but it can be helpful in sorting out potential diagnoses and afford a little bit of temporary treatment. Types of myomectomy include hysteroscopic, done to remove just the submucosal inner wall type, laparoscopy, when one or more small incisions are made into the abdomen to remove at most one or two fibroids that are up to a couple inches in diameter, growing on the outside of the uterus. A laparotomy is a larger incision made in the abdomen to remove larger fibroids, multiple fibroids, or deep-rooted growths within the uterine wall. Uterine fibroid embolization is a minimally invasive procedure that radiologists do to treat fibroids by blocking the arteries that supply blood to them. This process involves placing a catheter into the uterine artery by making a small incision at the top groin part of the leg. A needle is used to enter the artery and provide access for the catheter, and then guided by x-rays, small particles are injected into the arteries that feed the fibroids, resulting in blockage of blood flow and then subsequent dying or necrosis of these fibroids. Generally speaking, we don't use Lupron prior to UFE because it can affect the blood flow to the uterus. And the radiologist injecting the particles into the uterine artery needs to get a full picture of that blood flow. Endometriosis is characterized by chronic pelvic pain and sometimes abnormal bleeding. Endometriosis is the growth of endometrial tissue in other parts of the body, besides inside the uterus. Hot spots for endometrial growth can include the abdominal cavity, the ovaries, the fallopian tubes, the bowels, the outer surface of the uterus. These growths are essentially displaced uterine wall tissue, and they act as such. And they want to shed each month, just as the uterus does during a menstrual period, and they do. But if you're having bleeding that doesn't come out the vagina, that it bleeds into the muscle or bleeds into your abdominal cavity, that can be very painful. And when scar tissue develops over these lesions, it can actually interfere with organ functions. For example, when the tissue blocks fallopian tubes, a woman can be infertile. She may experience very few symptoms except for infertility and wonder why she can't get pregnant. Symptoms of endometriosis vary widely and can include pelvic pain, painful intercourse, infertility, abnormal periods, nausea and dizziness, exhaustion, bladder problems, painful bowel movements or irritable bowels, aching in the back, abdomen, and pelvic area, and other stomach problems. How is endometriosis treated? Laparoscopic surgery and hormonal therapy such as Lupron shots can be short-term alleviation. Laparoscopic surgery is a common procedure for removing mild to moderate amounts of endometriosis. Instead of using a big incision, the surgeon just inserts a tiny lighted viewing instrument. Pregnancy sometimes can improve endometriosis, and thiamine B1 has been shown to reduce menstrual cramps. So I frequently recommend 100 milligrams a day to women with menstrual cramps. And sometimes I'll recommend a nonsteroidal anti-inflammatory agent called meclofenamate, which reduces menstrual cramps and menstrual blood flow. Identifying and treating adenomyosis. Well, endometriosis is bleeding outside of the uterus, but adenomyosis is bleeding in the muscle of the uterus. And it's invasive but usually benign growth into the uterine muscle. How is adenomyosis treated? Well, if you have unexplained pain and the diagnostic testing indicates the cause is not fibroids, adenomyosis could be the culprit, particularly if you've had a C-section, which cuts the muscle. You could actually be bleeding inside these uterine muscles. Usually the best way to identify adenomyosis is with a pelvic MRI. Another option is to shut down the period and bleeding using either continuous birth control or a shot of Lupron, which puts a woman into medical menopause. When the bleeding stops, symptoms should stop. If the symptoms flare up again when you stop taking either birth control or Lupron, the adenomyosis might be the diagnosis. Adenomyosis is conventionally treated by hysterectomy, but non-surgical procedures can help. Many times insertion of that Mirena levonorgestrel intrauterine system will decrease bleeding and cramps, and it can be effective for up to 7 years while providing contraception if needed. So I think any woman contemplating either tubal ligation for sterilization or hysterectomy for menstrual disorder should consider the Mirena. Adenomyosis or fibroids. Fibroids are generally self-contained growths, while adenomyosis is overgrowth between the layers of the uterine muscle wall. What if my doctor can't determine the cause of my abnormal bleeding? Well, after ruling out infection, cancer, endometrial polyps, uterine fibroids, some physicians can ablate or physically destroy the uterine lining. This procedure is only appropriate in certain circumstances, and generally, many of us in the menopausal field do not favor any endometrial ablations. If you're still bleeding and the cause is not a bleeding disorder, if you can't, or if hormones taken continuously are not enough, and you know you don't want any further pregnancies, but it's not the first line of treatment, and sometimes it's one that's remunerated pretty well, so it might be one that your gynecologist is offering. If you're under the age of 40, you should definitely avoid it. It can usually only be performed twice before you require a hysterectomy, and it's really not a good option for women in their late 40s who are already close to menopause and bothered by menstrual flooding. And once you have an ablation, there's scarring, and when you enter menopause and need hormone therapy or want hormone therapy for the benefits and longevity, if there's any menstrual bleeding, we can't rule out that it's not cancer, and so you end up getting a hysterectomy. Meclamin, this and other nonsteroidal anti-inflammatory drugs can help slow down menstrual flow and reduce or stop cramping. We talked about the Mirena intrauterine system, and any hormonal contraceptive, pill, patch, or ring can be used continuously without a withdrawal period to prevent bleeding. Hysterectomy, become informed. Unfortunately, many women who bleed abnormally are just given a hysterectomy without other options, but you need to be counseled. Do you plan on having more children? Are you ready to lose your uterus? Are you prepared for menopause? Because even if your ovaries are left in place, there is decreased blood flow when these arteries are clamped and the tubes in uterus are removed. Depending on your reason for considering hysterectomy, your feelings may vary. If your mom had ovarian cancer and you want a full hysterectomy with removal of the ovaries, this procedure may be a way for you to gain peace of mind, but there are consequences to losing your ovaries. And for many women, it's not worth it. The situation is analogous to that of a woman whose mother had breast cancer, who she too learns that she has the BRCA gene. While one woman might choose to have her breast removed, mastectomy, maybe the newer nipple-sparing mastectomy, and reconstruction as a preventive measure, another woman might not want to go through that procedure, preferring to reduce her risk of breast and ovarian cancer by having the ovaries removed. If you decide to have your ovaries removed for prevention of breast and ovarian cancer, I strongly recommend that you have your uterus removed because BRCA1 is associated with a higher risk of uterine cancer. Many women who have their ovaries surgically removed have intense menopausal symptoms and need hormone therapy. And if you have a uterus, we have to deal with potential bleeding and the use of progesterone. The point is, your physician should outline pros and cons and let you decide. You should be engaged in the discussion, and you need to know the benefits and risk of such serious surgeries, and if there are other hysterectomy alternatives. Hysterectomy is the removal of the uterus, and women undergo this procedure for a variety of reasons. Gynecologic conditions, including childbirth complications like bleeding that won't stop, cancer, abnormal bleeding due to fibroids or endometriosis. And there are different types of hysterectomy. A partial one includes removal of the uterus, and it may or may not include removing the cervix. If you still have your cervix, you still need PAPs, and that's called a supracervical hysterectomy. When a woman says she has a complete hysterectomy, that means both the uterus tubes and ovaries. And a radical total hysterectomy involves the uterus, cervix, ovaries, as well as the structures that support the uterus and sometimes the lymph nodes. And this is an aggressive procedure that can be used to treat endometriosis and certain types of cancer. When is a hysterectomy not necessary? Many cases do not necessarily warrant hysterectomy. In these instances, the choice is yours. And abnormal bleeding doesn't mean you necessarily have to give up your uterus. And generally speaking, a single intramural fibroid is not a reason to undergo a hysterectomy. And if you're diagnosed with benign condition, which is common, your next stop doesn't need to be medical menopause. There are exceptions. Rarely, fibroids do degenerate into cancer or sarcoma, rapidly growing or causing severe pain and inflammation. If your physician suggests a hysterectomy for the following conditions, you might want to get a second or third opinion. Fibroids are a common reason, uterine prolapse, endometriosis, benign ovarian cyst, and they can be treated with ovarian suppression. It's severe PMS. It's very unusual to do a complete hysterectomy for severe PMS, and you need to undergo psychiatric evaluation and suppression of ovarian function, as well as treatment prior with the established agents to treat severe PMS. Adenomyosis, generally hysterectomy is the curative option, but sometimes the Mirena intrauterine system will do the trick. So when is hysterectomy non-negotiable? Well, if you carry the BRCA gene, which indicates a high risk for breast or ovarian cancer, we usually do recommend complete hysterectomy or at least removal of the tubes and ovaries after childbearing is complete by age 40, sometimes a little sooner for BRCA1. When pelvic procedures fail to treat endometriosis, many times a full hysterectomy is in order. If you have cervical cancer, you need a hysterectomy that includes removal of the cervix. Uterine cancers and ovarian cancers usually always require complete hysterectomy as well. In each case, there are implications that might influence your decision to remove the ovaries or the cervix or just parts of the whole. If you have the BRCA gene, some women do choose to keep their uterus and only have their ovaries removed laparoscopically, but in my opinion, once the ovaries are gone and you enter surgical menopause and you need to take estrogens to control your symptoms, if you need estrogen and have any kind of a uterus or endometrium left, you've got to take a progestogen. And it may be the progestogen that somewhat blocks the benefits of estrogen on the breast. And a synthetic progestogen to oral estrogen further increases the risk of blood clot. Save the cervix? Well, generally speaking, the cervix is usually removed at the time of hysterectomy. But in a very, very tiny percent of women, cervix may be an erogenous zone and they may choose to keep it. There are women who report sexual stimulation after cervical tapping. But in general, removing the cervix will not affect sexual function for the great majority of women. There are some prolapse and sling procedures for incontinence that require the cervix to stay in place. Be aware that if you keep your cervix, you still need to get PAPs, smears, and periodic HPV DNA tests. If you're going to have both ovaries removed, like I said, I usually recommend removal of the uterus too. It does take somewhat longer than just taking out the ovaries, though. If pelvic procedures did not treat your endometriosis, then you might need everything removed. If you're under age 65, unless you're at high risk for breast or ovarian cancer, we generally recommend that you keep your ovaries as there's a survival advantage to keeping them. So often there's more than one possibility for appropriate treatments or procedures, so you must be fully informed and aware of all your choices, because it truly is your body, your hormones, your choices. Now recently there's been some new medications that have been approved for fibroid treatment. Myfembree is a combination of hormones and that GnRH agonist that can be used to treat symptomatic fibroids in healthy premenopausal women for up to 2 years. It contains relugolix, which is a GnRH agonist to shrink the fibroids, and it also contains a little bit of natural estradiol and norethindrone acetate in like a menopausal type dose to prevent bone loss and treat the hot flashes, which is caused by the GnRH agonist. In medication trials, women taking Myfembree had more than an 80% reduction in their menstrual blood flow from baseline, which was much better than treatment to placebo. But you can get hot flashes, thinning of the hair, and decreased sex drive. And we don't use this combination medicine if you're over the age of 35 and smoke, or have any history of blood clot, stroke, or heart attack, or uncontrolled high blood pressure or high cholesterol. And women generally should not take this medicine if you are or would like to become pregnant in the near future. And we don't use this medicine if you have breast cancer, osteoporosis, liver disease, or other conditions where hormone therapy may not be indicated. Women taking these medicines can be at increased risk for increased blood sugar and lipid levels, so it's important to have periodic lab testing done. This medicine Myfembree can affect the absorption of other medicines, such as medicines used to treat an underactive thyroid or an underactive adrenal gland. So monitoring and dose adjustments might be needed. There is another treatment option for fibroids. Oriann, Oriahn, is another medicine used to treat heavy menstrual bleeding due to fibroids. And it's similar to Myfembree and was the first oral medicine of its kind to be FDA approved for this condition. Like Myfembree, it contains a GnRH agonist as well as an estrogen and progestin. We talked about uterine fibroid embolization, hysteroscopic myomectomy, laparoscopic myomectomy, intrauterine systems with a progestin IUD, and then finally, hysterectomy. If you suffer from uterine fibroids, you might want to download our free treatment guidebook on speakingofwomenshealth.com on fibroids and menstrual disorder treatment, free treatment guidebook. We have many free treatment guidebooks on our Speaking of Women's Health website. So thanks for joining me back in the Sunflower House. I am Dr. Holly Thacker, your host and author, and please be sure to join me for the conclusion of my book, The Cleveland Clinic Guide to Menopause. Please subscribe wherever you subscribe to podcasts and give us a 5-star rating.